happy to be here as a part of Allies. Hypertension is the most important modifiable cardiovascular risk factor and one of the leading causes of death. And however, hypertension is not controlled overall well. Coming to resistant hypertension, hypertension is considered resistant when blood pressure is more than 130 systolic and more than 80 diastolic despite use of 3 antihypertensive drugs at their optimal doses. And one of the agents should be a diuretic. Again, patients who need antihypertensive drugs which are more than 4 agents, they also come under resistant hypertension category. And BP should be, uncontrolled blood pressure should be confirmed by doing either home BP monitoring or ambulatory BP monitoring. We need to make sure that patient has been adherent to the drug strictly. Uncontrolled hypertension is not resistant hypertension. Patients are considered resistant only if they have truly tried and failed 3-drug regimen. Uncontrolled hypertension patients are those who have high blood pressure despite being on adequate dose of drugs because of poor adherence or because of undetected secondary hypertension or true resistant hypertension. Coming to pathophysiology of resistant hypertension is not known, thought to be multifactorial. Enhanced sympathetic tone, fluid and water retention plays a major role. Aldosterone has a major role to play in resistant hypertension, and also impaired baroreflex activity. Always exclude pseudo-resistance before labeling a patient as resistant hypertension. Pseudo-resistance is falsely high blood pressure secondary to poor, inadequate dose of medications, inaccurate measurement techniques, and also white coat hypertension, physician inertia to increase the dose of medications, or irrational combinations. When we say irrational combination, it could be beta blocker with a diuretic or beta blocker with a ARB. Sometimes it could be the vessel calcification which causes falsely high BP being labeled as resistant hypertension for the blood patient. There are certain medications which will interfere with the efficacy of antihypertensive drugs. They are oral contraceptives, NSAIDs, steroids, sympathomimetics like salbutamol, amphetamines, certain weight-reducing drugs like ephedra-alkaloids, erythropoietin analogs, and certain sodium-containing antacids. Always rule out secondary hypertension before you label a patient as resistant hypertension. When patient has hypokalemia, make sure that you are ruling out pheochromocytoma. If patient has persistent tachycardia, make sure that you are evaluating the patient for pheochromocytoma. And if the patient has symptoms suggestive of sleep apnea, do a sleep study. So who is a true resistant hypertension patient? This patient of mine, who is a 42-year-old male, obese, uncontrolled hypertension, OSA on CPAP, mild LV dysfunction secondary to hypertensive heart disease, on all these medications. However, his compliance with medications is very poor, and he continues to have a blood pressure of something like 190 by 100 despite all this medication. This is a true resistant hypertension patient. The prevalence is something like 12% in Asian population study and about 8% in this Spanish study. Prognosis in patients with resistant hypertension is poor. Their all-cause mortality is something like 2 to 4% per year, MACE rate of about 4 to 6% per year. There are certain predictors of resistant hypertension. This data from ALAD trial shows that the major predictors being left ventricular hypertrophy, CKD, obesity, and OSA. Coming to treatment, the traditional treatments are you motivate the patient to adhere to the drugs motivate them to follow diet restrictions and lifestyle modifications, and also make sure that they have been adhering to the drugs strictly. There are certain interventional strategies. They are renal artery stenting in renal artery stenosis, in appropriate cases, renal artery denervation. This is approved in India now. Carotid baroreflex activation therapy and central AV fistula creation. These are in research stage. So reducing the salt intake from high to low can reduce the blood pressure significantly. Studies have shown that systolic blood pressure can fall by 20, diastolic pressure can fall by 10 if you reduce the salt intake. So coming to pharmacological therapy, maximize the therapy, add a MRA. Without adding an MRA, either spironolactone, eplerenone, or finrenone, do not label a patient to have resistant hypertension. If the patient has CKD instead of MRA, you can go for a loop diuretic. Coming to medical therapy, increase the dosage of medication, optimize the combinations. Another pathway which is targeted, which may be of truly hope for the future for patients with resistant hypertension, is natriuretic peptide system, RNA with its effect on diuresis, natriuresis, sympathetic system, and vasodilatory effect is considered as a major good hope for the resistant hypertension patients in the future. Coming to diuretics, chlorthalidone is considered as a better antihypertensive drug than hydrochlorothiazide because of their longer duration of action and less hyponatremia with chlorthalidone compared to hydrochlorothiazide. 24-hour control of blood pressure is much better with chlorthalidone compared to hydrochlorothiazide. ASCOT trial has shown that adding spironolactone to hypertensive patients can reduce the systolic blood pressure by something like 20 millimeter of mercury and diastolic blood pressure by 10 millimeter of mercury. Always add a drug at bedtime. Adding a bedtime drug can reduce the overall 24-hour control of blood pressure much better than those patients who do not receive an agent at night. So coming to renal artery, stenting in renal artery stenosis, the indication has gone through wide pendulum swing over a period of last decade. About a decade back, we were doing more and more renal stenting, but not anymore. ACCHA and SKY recommends renal artery stenting for resistant hypertension only if the patient has resistant hypertension or the patient has high blood pressure, who are intolerant to antihypertensive drugs and who have hemodynamically significant renal artery stenosis. So who is a patient ideal candidate for renal artery stenting? This patient of mine who is 63-year-old lady, hypertensive, diabetic, uncontrolled hypertension, needing multiple hospitalization for hypertensive LVF. Her renal angiogram showed left renal artery 90% stenosis. She underwent successful renal artery stenting. Now this is nearly 10 months since she had the procedure, well-controlled blood pressure and no more hospitalization. Devices, RDN or renal denervation is the only device therapy approved as of now in India. And this causes damage to the afferent and different nerve endings in the renal artery, causing significant reduction in the blood pressure. This has CE mark approval, and ESC recommends for all patients with resistant hypertension and patients with uncontrolled hypertension who are intolerant to drugs. RDN has gone through significant technological and technical improvisation in the last more than a decade. The recent trial being spiral hypertension on medications and Radiance 2 has shown significant reduction in the blood pressure in the treatment arm compared to the control arm. This is how the spiral catheter will look like. This is the procedure recently done in our place, and thanks to Rifai for this slide. This is how the procedure is done. And of course, the future will be non-invasive denervation, wherein several piezoelectric transducers are used to send high-frequency sound waves to cause damage to the nerve endings in the renal artery. There are several other devices available which are in research stage. These are the different devices available. And who is the ideal patient for RDN? This is the same patient whom I said, the resistant hypertension patient, this man is awaiting RDN, that is renal denervation. Different newer drugs are on research and trial. Two major drug systems which will be of major hope for the future will be natriuretic peptide system and gliflozins because of their pleiotropic effect on diuresis, natriuresis, and sympathetic and aldosterone system. If you see a patient with resistant hypertension, first rule out pseudo-hypertension, identify contributing factors, discontinue medications which can interfere with the efficacy of the drug, rule out secondary hypertension, increase the dose of medications, renal artery stenting, appropriate cases, and finally, if nothing works, renal denervation. So I would like to conclude saying that the treatment of hypertension has to be individualized because one size doesn't fit all and one size doesn't fit one all the times. So my take-home message would be always exclude pseudo-resistant, motivate the patient for lifestyle factors, check adherence to the drugs, sleep study, renal artery Doppler whenever needed, add a MRA if needed, furosemide in CKD patient, always add a drug at night, old is still gold, so you may add clonidine hydralazine if needed, renal artery stenting in appropriate cases, renal artery denervation may be the hope for the future. Thank you.
Thanks a lot, Dr. Rajeshwari, especially the last before slide, which one size will not fit everyone. It's a very, very distinct message. And now we are open for the Q&A. And as we said, 4 minutes, and one person can ask one question only to give opportunities to all.
He did not improve. Yesterday, when I measured the patient at 8 o'clock, at 12 o'clock, at 4 o'clock, at 9 o'clock, each differed by 40 units, 40 mm. Does this patient require spironolactone, or does he need further investigation, especially renal artery stenosis?
Yes,
or
sir.
does he need further investigation of aortic calcification? What is the most ideal investigation that you may suggest?
What are the drugs he is on, sir, as of now? What is he taking? Huh? So at least 3 drugs of different classes along with MRA will be ideal drug for him. That means maybe you can add a vasodilator in the form of amlodipine or cilnidipine, one of the ARBs.
Spironolactone is the last resort.
Yes,
Not
controlled.
What is the most ideal?
Renal Doppler has to be done. If the patient has sleep apnea, always rule out OSA. If the patient has persistent tachycardia, always rule out secondary hypertension. Do a pheochromocytoma study, that is metanephrines, hypokalemia, rule out hyperaldosteronism. All this has to be done. Then only you will label a patient as resistant hypertension. Maybe hypertensive heart disease, because uncontrolled hypertension going in for so long, we have to optimize the drug. If you could tell me exactly what medications he is on, I'll be able to answer better, sir.
I think the point is conveyed. Secondary causes should be aggressively ruled out. You should take recourse to a CT abdomen with angiography to rule out the rare causes like arsenides. Okay, so as a general rule, we're not talking about the individual patients here. So the general rule is secondary causes should be aggressively ruled out. In fact, you take use of the nuclear scan technology. Gallium DOTA scan is a very useful test to pick up all somatostatin avid tumors like pheo. If you don't do that, you might miss. Even in fact, we do find pheochromocytomas coming up into the picture at the age of 70 years. So I think a good aggressive secondary cause outlook should be important. Sleep apnea should be ruled out in all cases of resistant hypertension, including in people who are not obese. This is a very important message. I think Raji has covered almost all the areas of secondary hypertension.
So one more thing, sir.
We are very fortunate that we'll be having the doctors available for a one-on-one session. So for a detailed questions, and you can always approach them. And since we are running short of time, so the next question, please.
Sir, actually, patients who are on steroids, corticosteroids, if they develop hypertension, what will be the ideal antihypertensive to use?
I did not get the...
Patient is on steroids. If they develop hypertension,
Yeah.
what is the ideal drug antihypertensive you can advise them?
Yeah. First line of drug will be vasodilator, ARB, and a diuretic, definitely. For some reason, patient has to be on high dose of steroids, continue the steroids and increase the dose of medication, or if you can reduce the dose of diuretics, that will be ideal. But only thing, always look for hyperkalemia.
Thank you.